Welcome back to part 2 of MCAS in Long Covid, Mast Cell Activation Syndrome. So, like I said before, I'm Dr. Tim Robinson, formerly a family doctor for 30 years, now Long Covid Services for 5 years, posting on podcast channels and YouTube. I hope you find them helpful. If you like them, click subscribe. I have to add my usual disclaimer. Any advice or treatment I mention should only be considered after talking to your own doctor. So, part 1, what did I talk about? Basically, mast cell activation syndrome itself. Gave you the explanations in order for you to understand what is happening. Talked about mast cells themselves, talked about how they are part of the innate immune system, and I then went on to the causes for the release of their components. So now here we are, part 2. I'll talk about how we're going to tackle those naughty old mast cells. So, as I said, a quick recap. Mast cells, part of the innate immune system, releasing the histamine, and histamine causes all sorts of symptoms. So the MCAS symptoms, particularly in the gut, the skin and the respiratory tract, but also throughout the whole body, particularly the muscles, the joints, leading to fatigue and brain fog and dysautonomia. So the diagnosis of mast cell activation syndrome, I remember explaining to you that, a lot of people ask us, can we measure something? Can we make the diagnosis having measured something, and therefore we have something concrete that proves that we have it? Well, as I explained, the blood tests and the urine tests are not widely available. They're difficult to perform, and so therefore actually diagnosis is based on the combination of symptoms. And remember, a syndrome is a combination of symptoms that suggest a condition. Okay, so the diagnosis of mast cell activation syndrome is based on that combination of symptoms, and it is confirmed with mast cell activation treatment. So, question: what is the treatment for mast cell activation syndrome? Well, let's go back to first principles again. Remember, mast cells, I explained, have receptors on them. Lots of receptors, but the two types of receptor that are there in greatest sort of numbers are the H1 and H2 receptors, the histamine 1 and histamine 2 receptors on the cell membrane. When a virus comes along, so the SARS-CoV-2 virus, the COVID virus, came along and attached itself to the H1, H2 receptors, that brought about disruption of the membrane, breakage of the membrane, opening up of the membrane of the mast cell, and then release of histamine and all the other up to 1,000 pro-inflammatory mediators, but particularly mast cell. So therefore, if the problem comes as a result of those mast cells spilling all their guts and gubbins out into the tissues where they're sitting, it would be nice, wouldn't it, if we could block that happening, if we could stop the mast cells breaking down and opening up and releasing their histamine, etc. So we need to be able to therefore block the H1, H2, histamine 1, histamine 2 receptors. Then we'd have a solution, wouldn't we? So how are we going to do that? Well, we need, if we're going to try and block H1, H2 receptors, we need H1, H2 blockers. Okay, let's think about each in turn. So first of all, H1 blocker, the histamine 1 receptor blocker. What are they? Well, basically, they're a class of drugs we're very familiar with, antihistamines. And the antihistamines that we advise and prefer and are best tolerated are the three big ones are cetirizine, fexofenadine, and loratadine. So cetirizine 10 milligrams, fexofenadine 180 milligrams, loratadine 10 milligrams. These are what's known as second generation antihistamines. So first generation antihistamine you will all be familiar with, and that is Piriton, chlorphenamine, and basically that's been around. Piriton's been around for 50, 60, whatever years or more. I don't know. Yeah, probably 60 years. Yeah, a bit similar to me. My 60 years, 65 years actually. So these are first generation. Piriton is a first generation antihistamine, which is very good at dealing with hay fever, but it wasn't that brilliant that well tolerated because it brought sedation. So its side effect is sedation. So that's why we don't necessarily turn to Piriton as the first line antihistamine anymore. As I say, we use cetirizine, fexofenadine, loratadine. So if you look at the label or the prescription, it will say 1 a day, and that's what's on the box, because after all, you can buy it over the counter in the pharmacy, and that's what it says, 1 a day. However, specialists, dermatologists, and immunologists use these 3 antihistamines in much higher doses. So dermatologists for a condition called solar urticaria. So it's the same sort of underlying mechanism and process that brings about this urticaria triggered by the sun, otherwise known as hives. But patients who have really terrible solar urticaria or pruritus, generalized skin irritation, the dermatologists prescribe much higher doses, up to 4 times what's on the box. So to cetirizine, 10 milligrams, no, they prescribe 20 milligrams twice daily. Likewise, the immunologists for a condition called idiopathic angioedema, so sort of swelling of the lips and swelling of the tongue and sort of tight throat that occurs because of part of an allergic type process. They also prescribe these second generation antihistamines at those sort of high doses. So our experience in long COVID world, and this is talking globally, is that yes, we use higher doses. Often we need much higher doses, but we feel comfortable with twice daily dose, not the once daily that's on the box label. So twice daily dose. If you find that you're getting some relief from your symptoms, but you still have those symptoms, discuss that with the doctor, your own GP, who may well actually say, all right, these are safe drugs, excellent safety profile, so let's try a higher dose. Certainly in long COVID world, we always recommend a doubling dose. Not initially. First of all, a low dose, so the once a day dose, and then increasing. I'll come on to that in a minute. So that's H1 blockers, histamine 1 receptor blockers. Like I said, we have H1 and H2 receptors on the cell membrane of our mast cells. So we need now an H2 blocker, don't we, to work with the H1 blocker to prevent release of the mast cell contents. And the H2 blocker that is used is famotidine, 20 milligrams. Famotidine is an stomach acid indigestion drug. You may have heard of cimetidine, which came out in the the late 70s, 4 times a day, but had some side effects. You may have heard of side effects being interaction with something called the cytochrome P450 pathway in the liver, but also caused a lot of men to develop gynecomastia. So it's in a way, and it was 4 times a day drug to be taken. So that was fell by the wayside, and that was replaced by ranitidine, which some researchers found had adverse effects, potential adverse effects, and maybe even a cancerous leading condition. So that was also, binned. And so then famotidine was developed, which is safe. So as I said, it is used for indigestion for those patients who can't take the, if you like, superior anti-acid tablet, the proton pump inhibitors, so omeprazole, lansoprazole, etc. We've got famotidine to take in its place. The nice thing about famotidine is not only is it an H2 blocker, but it also has, they found, anti-inflammatory effects. Well, that's a win-win, isn't it? Again, this is a once daily treatment, and that's what's on its license, if you like. It's data sheet license. But our experience in long COVID world, again, is double dose, so twice daily. Again, like before, you'd start with once a day, and if you felt a benefit, but actually you wondered whether the benefit would be even greater, an increased dose, don't double them up yourself. Talk to your GP first. But like I said, there are in actual fact quite a few H receptors, but the 1 and 2 are the main ones on the mast cells. And so in a way you want to lock or block both those receptors. So the H1s and H2s are receptor blockers. The H blockers, the H1 and H2 blockers are usually prescribed at the same time, because in a way they work synergistically. There's an additive effect. So you will get an effect with just using one H1 blocker, but you get a better effect by using the combination of the antihistamine with the anti-acid tablet. So like I said, start with one a day or once a day, because that's what it says on the box, isn't it? Okay. So if after 4 weeks you're no better and you still, have all those symptoms that I outlined in the first part of histamine symptoms in all the systems, then increasing to twice daily with obviously the permission of your doctor. A question that is frequently asked is, okay, I get this. Patients say, yeah, I get this and I get some benefit from it, but how long am I going to be needing to have this treatment? So basically, how long for, and, in the initial prescription, how long would it be reasonable to continue it for? Our experience is that, you'd keep it going for 3 months, as long as you're tolerating it. Okay. If you're getting that benefit, then at 3 months, you're asking that question, well, do I still need it? I don't want to take medicines unnecessarily ad infinitum if they're not needed. So what would you do? So therefore, you'd sort of have a trial period off the medicine. So wean off the tablet from twice a day down to once a day, and then stop it and see what happens. If the symptoms have settled, happy days, wonderful. The mast cell activation the MCAS has settled down, probably in line with the general settling down of inflammation in the body, which happens in long COVID eventually. So wonderful. If the symptoms aren't there anymore, upon discontinuation of the tablet, then you don't need it. If, however, after discontinuing the tablet, the symptoms all come back in a rush, you basically think, okay, well, my MCAS is still there. I still have histamine symptoms. And so therefore, it's logical to restart the tablet. You're going to want to restart it, aren't you? To ease those symptoms again. And so that's the way to proceed. So every 3 months, and then you do it again. You do another trial 3 months later, and then another 3 months later, and then another 3 months later. We've got patients who have been on H1, H2 blockers for certainly up to a year, if not more. So it's a case of keep using it until you don't need it, until your symptoms settle and stay settled upon discontinuation of the tablet. What else can we do besides H1 and H2 blockers? Well, we can actually use drugs that stabilize the wall of the mast cell. So these work slightly differently. As I say, H1 and H2 blockers actually just block those receptors. So it would be lovely in order to prevent mast cell degranulation or release of those components, is to actually just, steady and stabilize the membrane, the wall of the mast cell. And can do that by using a couple of drugs we've got up our sleeve. So first of all, we've got ketotifen, which is a mast cell stabilizer. It is in actual fact a second generation antihistamine as well, which is good, isn't it? Because you think to yourself, hold on, I'm actually tackling this MCAS from two approaches. One is stabilizing the membrane, and two is blocking the H1, H2 blockers, receptors. And it gets better in that ketotifen also has what we call leukotriene antagonist action. So leukotriene is an inflammatory mediator. So if it blocks those inflammatory mediators, there we are. We've got a win-win-win. And it could be used in place of cetirizine. Cetirizine is preferred. Remember, cetirizine, one of the 3 second generation antihistamines I listed. Cetirizine 10 milligrams, initially once a day, then up to twice a day. It could be used in its place along with famotidine. So ketotifen could be used in the place of cetirizine along with famotidine. The only slight reservation I have is that it's not as strong as cetirizine in its H1 blockade. The other problem is sedation. So it's got a bit of the first generation Piriton sedative effects about it. So not good. So if you are going to try it, okay, start with 1 milligram at night. Why? Because obviously that will help you sleep. That's a good thing, and therefore you won't have daytime sleepiness if you take it if you had taken it in the morning. Or so start with 1 milligram and then bump it up to 2 milligrams if you need. So that's a mast cell stabilizer. Another mast cell stabilizer is chromoglycate in tablet form. You may be familiar with it in eye drop form. We use it for hay fever sufferers who have particularly itchy and red eyes with their hay fever. And we prescribe this on a 4 times a day basis to dampen that eye irritation. Chromoglycate is prepared in tablet form as well, and it is to be taken 4 times a day. However, and of course there's always a however, isn't there? It's extremely expensive, and it's not on GP formularies, general practitioner formularies, so GPs don't have access to it. It is a prescription-only medicine, so you can't even buy it online or in pharmacies privately, only with a prescription. And actually, chromoglycate tablets have fallen out of favour because they've been replaced by something called montelukast, which is a leukotriene antagonist. Remember what I said about ketotifen? Its third big sort of plus point was it had leukotriene antagonist action. There's a drug called montelukast, which is a leukotriene antagonist. That has taken the place of chromoglycate as a tablet. So I think it's really chromoglycate, even though the concept is amazing because it's a mast cell stabilizer, actually it's not really on offer. And then the third mast cell stabilizer, and this is interesting, is a herbal supplement called quercetin. Quercetin is a naturally occurring antioxidant. So antioxidant is a plant substance, a plant chemical, which mops up free radicals, those destructive byproducts of metabolism that happen. We all have these in our cells, but they're mopped up by our own antioxidants within which we make. But there's this plant source chemical, a polyphenol called quercetin, that basically, as I said, is an antioxidant, but it also is a mast cell stabilizer. And this is backed up by studies. Studies show that it has, and research studies and published in journals, etc., it shows that it has mast cell stabilizing properties, which is a good property for this situation. And you can buy this over the counter. Quercetin is safe. It is a naturally occurring plant product that's present in fruit and veg. I mean, throughout it's the most commonly occurring plant polyphenol. One slight reservation, of course, is anything herbal. Got to watch out for. Got to be very careful of, because they can interact with other medications that you're taking, conventional medications. So beware that you don't take it lightly. Look at the contraindications on the list, in the box. Talk to your doctor. It's something that you've got to be aware of. You don't want to create further problems by clashing drugs against herbal medicines. So there we are. So in a way, I've focused on the conventional medications, and then at the end I came in with quercetin, sort of, as I could say, sort of a herbal preparation. And its action really is to reduce inflammation. And as we know, in long COVID is all to do with inflammation, isn't it? Inflammation through the whole body, inflammation of the blood vessels, what we call endothelialitis. But inflammation is at the heart of all long COVID problems, along with other things, like viral reactivation and perhaps persistence and immune system dysfunction, and etc. But basically, if we can dampen down inflammation, that is a good thing. And one of the easiest and most logical and sensible things to help dampen down inflammation is nutrition, your diet. Okay. Okay, what do I mean by that? Okay, and what do we recommend? Basically, we need a mixed balanced diet, like a Mediterranean diet, which is an anti-inflammatory diet. Remember that one of the areas where mast cells is in greatest concentration is in the gut lining, and hence the lower gut problems, the upper gut problems that I described. So, loose motions and the gas and the bloating. These, in my experience over all these years of doing long COVID and working with long COVID and hearing stories from long COVID patients, these are the commonest symptoms, these gut symptoms. And remember the intolerance, I forgot to mention, intolerance of wheat and dairy and other food components. These MCAS symptoms these histamine symptoms are probably the commonest symptoms in MCAS. So it'd be nice to be able to tackle them. And what I'm saying is a mixed balanced diet, an anti-inflammatory diet, will help. And the reason why is that a mixed balanced diet, a diet in which the balance between the protein and the carbohydrate and the fats are balanced, okay, and mixed in the sense of you eating the rainbow of fruits and veg, all the different colours, means that all those different fruits, colours, and the veg and the fruit mean that they all bringing a different polyphenol to the table, if you like. And so all of those polyphenols will have their own anti-inflammatory properties, antioxidant, anti-inflammatory properties, as well as other sort of benefits. So to have a mixed balanced diet is an anti-inflammatory diet because of all those polyphenols you're getting. The other benefit of having a mixed balanced diet is that it will contain lots of what we call prebiotic fiber. That is fiber that nourishes the gut microbiota. And we know through studies that patients with long COVID, their gut microbiota is not normal. So it's not as friendly, in inverted commas, as it could be or should be. And we need a friendly microbiota, friendly gut flora, for lots of reasons. One is to sort of support the immune system. That's really important, which obviously, that's a key factor in long COVID. And then you've got other functions like a healthy microbiota breaks down short-chain fatty acids, which produce energy for the lining of the gut and stops the gut becoming leaky and permitting sort of toxins and bacteria getting into the circulation. Friendly bacteria also bring about the production of vitamin K and the absorption of vitamin B12 and the production of neurotransmitters. So serotonin and GABA and dopamine are made in the large intestine. They're absorbed into the circulation and find their way up into the brain. And also production of melatonin occurs in the large bowel. Melatonin, this natural sleep enhancing hormone that we all have concentrated in our pineal gland. And basically when it's dark, it squirts out from the pineal gland and enhances our sleep, our circadian rhythm, supports that day-night cycle. And incidentally, it is an antioxidant as well. So these are all the reasons why a healthy microbiota is really important for general recovery from the inflammation of long COVID, but also the normal functioning of all the systems in the body. And we feed that microbiota with prebiotic fiber. And foods that we should be thinking about are basically sort of onions and leeks and sort of artichoke and banana. So friendly bacteria love those. So give them a treat. In our long COVID clinics, we have patients asking, okay, well, diet. I've done some research. I know all about histamine. And if my symptoms are due to excessive histamine, doesn't it make sense to reduce the histamine intake? I.e., should I put myself on a low histamine diet? That's what patients ask. Fair enough. Good thought. Sounds logical, doesn't it? Yes. Right. Histamine. Histamine, what foods contain histamine? Well, basically, most foods contain histamine. Certainly the cheeses, the hard cheeses, the sort of the Stiltons of this world, and smoked meats, so sausages and salami, and tinned fish, so tuna, sardines, and oranges. Lots of histamine in the skin of apples, for example, and pears, but certainly within oranges and bananas themselves. Talked about bananas and what we should be having to feed our healthy bacteria, but bananas and spinach and tomatoes and also wine and beer has histamine, and peanuts and tree nuts. So lots of histamine everywhere. Okay, so if you're going to put yourself on a low histamine diet, it means you've got to rule all these things out. Okay, which is not easy. And it doesn't really leave a lot to survive on, does it? So this elimination diet, is depriving you of lots of proteins, lots of vitamins, lots of antioxidants, lots of minerals, which are necessary for our cellular repair, our immune support, our general healing. That's what the low histamine diet can do. Interestingly enough, the British Dietetic Association, so these are the sort of, if you like, the governing body, the regulatory body for dietitians in the UK. You look at their website and look at low histamine diet and long COVID and what their recommendations are. Basically, they're not very supportive of it for all the reasons I've given, that you're depriving yourself of those dietary components which are really important for general body maintenance and homeostasis and rebalancing and repair, etc., etc. So really, they're more in favour of a Mediterranean diet, actually. So there we are. That's the BDA. The other question that seems to come up once in a while is, should I be taking DAO? DAO. So what's DAO? Diamine oxidase. Okay. Diamine oxidase is a chemical that we all make in ourselves, and it's made in the gut, and its function is to break down histamine. Sounds like a good thing to have, doesn't it? Because our MCAS is all to do with excessive histamine. If we can reduce it, that's a good thing, isn't it? So why aren't all our MCAS sufferers having DAO? Well, okay, it has been researched, and actually the research is really weak, but not necessarily in favour. So the actual quality of research is weak, but it's not in favour. It's not showing favourable outcomes. And there are lots of countries in the world where it's actually banned. So the short answer is no. I think I would steer people away from taking DAO. It's certainly not on the NICE guidelines for management of long COVID. NICE guidelines, so that's the National Institute of Clinical and Health Excellence. It's not on the NICE guidelines for long COVID. So we actually have to advise against it. Okay. So really the answer, of course, again, back to basics and back to the logical, sensible option, mixed balanced diet, Mediterranean diet. Another question that does come up very frequently, and that is patients ask, should I see an immunologist or an allergy specialist? So, immunologist, well, probably not. Why? What's an immunologist do? An immunologist is someone who looks into the immune system, who knows everything about the immune system. And as we all know, the immune system is complicated, extremely complicated. The innate immune system, the acquired immune system, antibodies, B cells, T cells, natural killer cells, cytotoxic T cells, T helper cells, macrophages, basophils. You know, the list is long. And so that's what immunologists do. So patients ask, should I see an immunologist? Because, you know, all the research I'm doing, all the reading I'm doing tells me that my immune system's, you know, up the spout. So basically, actually, you probably don't, was my answer. Probably don't, because a GP will have done the panel of blood tests looking at what we call the full blood picture, okay? And specifically, the white blood cells. The white blood cells are the, if you like, the defensive, the line of cells that defend the body against inflammation and infection. You might have heard of neutrophils and eosinophils and basophils and lymphocytes, particularly B and T lymphocytes. So the GP will have done a blood test, this full blood picture, in which you'll have the WBC, the white blood cell count. And so as long as that's within normal parameters, then actually you don't need if you've got all the cogs in the machine that is the immune machine working. You've also, the other blood test that the GP requests is immunoglobulins, and you may well have heard of the IgGs and IgMs and IgEs. So these immunoglobulins are, if you like, the antibodies. So if the levels of your immunoglobulins are normal in your blood test, there's no need to see an immunologist. Rarely you can have what's known as a complement C3, C4 blood test, which also looks at another element of the immune system, especially the autoimmune system. So if all of those blood tests are normal, then you don't have an immune problem necessarily. So you probably don't need to see an immunologist. A GP would refer you to an immunologist if you are having unexplained, strange infections on a recurring basis, with or without abnormal blood tests. So I think that would be the indicator for a referral to an immunologist. So that's the answer I usually give when patients request or ask whether it's necessary to see an immunologist, yes or no. Like I said, the other question that I'm asked is, do I need to see an allergy specialist? Well, you know, why would people want that? Well, they want that because they've obviously, you know, thought, you know, there's histamine, allergy, hay fever, maybe this is an allergic process. Need to see an allergist. Should I be allergy tested? Okay. The other thing is that like I've explained, histamine brings about unexplained or not previously experienced food intolerances to dairy and wheat and gluten. So therefore, you know, again, that's another reason why patients ask, you know, do I need, you know, food allergy testing? Well, again, probably not. The GP can request a blood test called an IgE, immunoglobulin E. I was just talking about immunoglobulins. So the IgE blood test, they can request that. That's actually usually normal, unless there's a severe allergic process going on. And if there's a severe allergic process going on, a GP will refer you to an allergist, but not sort of for mast cell activation, not for mast cell activation level symptoms. If you do suspect that you might have an intolerance to a particular food, the more logical thing to do is to put yourself on an elimination diet. Eliminate the food that you think that you're intolerant to, and monitor yourself, monitor your condition, your symptoms. And like I said, start with wheat. That's usually the commonest intolerance. Dairy as well. Start one first and eliminate it. They say for wheat allergy, you should eliminate it for 3 to 4 weeks before you can actually see an improvement, see a change if you are wheat intolerant. Dairy and other foods components, you don't have to wait as long as that. So in a way, I'm focusing a lot on gut, aren't I? And sort of upper respiratory type, allergic-y type symptoms. What about skin? Well, again, it depends on how bad the symptoms are. Yes, it may be justified for your GP to refer you to a dermatologist if you have particularly troublesome skin rashes that are, not responding to antihistamines for your presumed diagnosis of MCAS. So yes, maybe referral to a dermatologist for skin prick testing is relevant, but not just at the first hurdle. So there we are. So where have we got to? So let's have a little summing up. Okay, mast cell activation syndrome, the problems and the solutions. Like I've said, whatever you do, safety first. If you've got a new symptom, report it to your doctor. Don't be COVID blind. Safety first. I've talked about the causes for mast cell activation, and the reason I talked at length, didn't I, about it? But I really wanted you to have a grasp of what happens in mast cell activation syndrome in order for your validation, in order for you to help accept it, in order for us to be able to treat it with the appropriate treatments. And that, remember, the H1 and H2 blockers. I then went on, looking at a bigger picture, the sort of the immune support, the anti-inflammatory diet, not a low histamine diet. Okay, please. Don't forget the other strategies, though. Remember the bigger picture, the long COVID picture. We need to treat mast cell activation along with the whole of the long COVID picture. Let's not treat mast cell activation syndrome in isolation. So we need to be using those other strategies for the fatigue of long COVID, the 3 Ps, the planning, the prioritizing, and the pacing. We need to sort of gentle reconditioning with stretching of the muscles with physiotherapist, or better still, yoga. And then mindfulness, remembering, focusing on the now, thinking of the sort of the mind-body balance, calming the brain, calming the mind, basically encourages the immune system. We know that there's a link, it's proven that there's a link between mind, body, and the support of the immune system. And sleep. I talked earlier about the melatonin and the production of it in the large bowel. Well, just think sleep. Sleep's really important for restoration of the body and the systems. So, like I said, the long and short is, let's not focus on MCAS in isolation. Let's focus on the whole picture and include MCAS strategies along with all the other strategies. So there we are. MCAS, you know all about it. Mast cell activation syndrome. I hope you found that helpful. As I said at the start, this is an educational series for long COVID sufferers. But remember, my usual disclaimer, any advice or treatments I've mentioned, discuss with your doctor. Remember, safety first. If this has been helpful, click subscribe, spread the word. I need to get these out to as many long COVID sufferers and their carers and friends and family as possible, to try and help them understand it all and to try and help in their recovery. So thanks again for the feedback. Again, apologies. You're not going to get a reply from me because I haven't got the time. Busy. Appreciated though, because it helps me with my future podcasts and postings. So in the meantime, I wish you well and with your long COVID recovery. So all the very best to you all. Cheerio.